for the next session. Hosted next session's host is Shona. She's a professor in the law school at Case Western. Shona, can see your.
You stand here for the technical.
Okay, sure.
Yes. Okay, well, welcome everybody to our afternoon session. I think it's been a great conference so far, and we are going to switch gears a little bit and talk about the legal and ethical implications of pandemic preparedness and response. And the legal and ethical considerations may not be the first to jump to mind, but they absolutely have to be a priority. We saw what power the courts had during the COVID-19 pandemic, and we saw how the law could both support but sometimes impede pandemic responses. And so we're going to explore all of that in the next hour and a half. We are going to start with Chuck Curran, who is an attorney and a data policy consultant at his own firm. And we're just going to try to get the slides up. Does he need to share it? He's up here. Yeah. Okay.
Sharing. Let me do it. Not sharing. Okay, go ahead.
Thank you. Can everybody hear me online too? I'm double checking.
Can you give us an indication if you can hear us, please? Somebody unmute.
Yes, we can hear you.
Great. Thanks so much, Brian.
And we're changing out of order here. I probably stipulate that I'm going to be talking about novel data sources for the pandemic response. And I wanted to stipulate that that's probably, compared to some of the things that we've been talking about earlier this morning, particularly what one of my co-panelists is going to talk about using health information exchanges. Those have been really done the hero's work of data integration. But I am going to talk about novel data sources as and really the legal considerations that go around their use for pandemic response. What the current guardrails and limits are, and how we can understand them and use them to basically let me see if I can advance this, to respond better and better take advantage of this data source in the future. And when I talk about novel data sources, I'm really talking about data outside of the traditional clinical care and established public health reporting channels. Although there's been really important expansions of the electronic health record requirements and the data elements to include public health and social determinants data, we're really focusing here on things that come from the commercial sector, online and the like. Prior to COVID, there was something of a literature around what novel data streams could be harnessed from the online world. Dylan George, who's now the CDC's Director of Outbreak Analytics, was writing about this topic. And in his definition, it was user-initiated data, that which the user provided in an interaction with an online platform. But as we saw from COVID, it's certainly expanded. The utility goes to really everything to do with online and mobile platforms and everything that's tethered to a mobile device. And the spectrum for novel population data, obviously, when you think about the instrumented environment, it's not just wastewater surveillance, but it's really the whole spectrum of the Internet of Things, smart everything, and the cross-purposing of other devices. So, got that. So with COVID, we saw, the most expected uses of online data, Twitter data providing predictive models, a couple of days clearance, maybe not as good as the Ohio model described earlier today, but a couple of days lead time with people discussing COVID symptoms or online and social media. And we also saw a resurgence of interest in search results. Flu trends had, Google Flu Trends has had a somewhat checkered history, but there were meaningful uses of symptom searches in UK studies with the NHS to essentially to use online data for what it is best suited for an advanced prediction and signal where cases have not yet hit the ER and hit the syndromic surveillance networks. You also saw a flourishing of mobile tools specifically developed for a public health purpose, and you have various models for that, largely built around apps. I've got an image up there for the Zoe symptom reporting app developed in the US with Mass General, developed in the UK, very high uptake. A rather successful example of actually using these technologies as a primary data source. And then also, all of you have undoubtedly encountered vSafe, which was built by Oracle for CDC. And then probably most conspicuously, the exposure notification apps, largely built by Google and Apple and furnished and fronted by a state public health, actually the backbone running on a federally funded server at the Association of Public Health Laboratories. But there are also the sort of public health as a secondary use for data gathered in from the online context where it's being used for a different primary purpose. Consumer wearables are obviously the most conspicuous example. You have the watches, the fitness apps, the rings, whatever form factors you can imagine that enable a tethered sensor to a mobile device. Excellent penetration in the US population, and therefore some great opportunities for scaled data. And certainly entities like Scripps with Eric Topol have done amazing work trying to use and harness this data for predictive analysis of COVID symptoms. And I also mentioned there are sort of hybrid applications like the Kinza smart thermometer that have both a personal healthcare and an intentional public health component. Mobile data, obviously very conspicuously used. I think it is worth drawing a distinction between data derived from apps and Wi-Fi signals, which is the predominant type of data gathered in the US for population adherence to stay-at-home mandates and lockdowns. In Europe and in Asia, much more involvement from the telecom carriers to provide cell phone location data. But again, examples of secondary use of data, a secondary public health use of geolocation data from phones. I'll just talk briefly about some challenges of standardization and sustainability. Obviously, all of this data developed for the consumer market. There are significant limitations on its scalability, where there are different. Sorry. There are challenges for accuracy, interoperability, merging, sensor standards that are developed outside of the health context and merging those in with in a language that health systems understand. And then, of course, same as for the electronic health record, questions around access to data through APIs, and mainly in bulk for public health purposes. And then, of course, when we even talk about standardization of these novel data sources, you have some of their, foundational limitations. The question of the validation of their use for various forms of public health intervention, with surveillance being the weakest form and individual detection and interdiction being the strongest form. And obviously that's politically fraught. And then, and it's, obviously 87% mobile phone penetration is not good enough from an equity perspective. when you're missing the most at-risk population for COVID in terms of those with least access to digital resources and the barriers of digital literacy, affordability, and really and also historical skepticism of sharing data with about health in certain populations. So on a sustainability, it is a question where you move outside of the clinical care system, where you have long-term, really a long-term funding mechanism and the ability of HHS and CMS to incentivize the collection of important public health data points for all these consumer applications and wearables. And you have really a different business model and a different justifications for why the data is collected in the first place. So the question is, to the extent that we want in the next pandemic to have this data type available, do we intend to, how do we intend to fund it, or how do we intend to borrow it or share it with the largely for-profit entities that are gathering these novel data sets? And then, of course, there's certainly rights concerns with access to, particularly, as I'll talk about in the Dobbs context, a real concern about access to personal mobility data and a real very vigorous pushback by state and federal lawmakers about public health's attempts to buy on the secondary market, to buy mobility data from data brokers who are extracting and harvesting that data from apps in the US market. So what are the primary legal hurdles for this kind of secondary use of novel health data? Really, three things I wanted to talk about. First is the issue of de-identification grows in complexity, where we see essentially different de-identification standards applicable in the HIPAA context to that which are applied outside in the commercial marketplace, and largely as a result of an attempt to rein in the excesses of the commercial market. So in brief, we're getting laws that are attempting to impose a more rigorous de-identification requirements with more accountability. And so to the extent that you're attempting on a public health basis to integrate both clinical and non-clinical data, you have the challenge, and trying to do record linkage, you have the challenge of actually trying to map to discrete legal regimes. They're similar, but they're not the same. And I'll just pause to say that Dobbs, there was already a trend towards.
You might say what Dobbs is.
Oh, sorry. Dobbs, the decision for the Supreme Court last summer, last June, overturning Roe v. Wade, has really there were already really kind of tectonic trends towards greater regulation of data and attempts to pass national privacy legislation. But Dobbs has really pivoted the focus to enhancing the protection of health data, reproductive health data in particular, in all of its particular manifestations, particularly its online, its search, geolocation, all of those things where with a patient seeking care. So Dobbs, and I urge all of you to take a look at the new Washington State privacy law. That's Washington, the state, not DC. Passed last week, which really raises the bar on the protection for health data outside a HIPAA context. And one of the key characteristics of this heightened regulation is the imposition of affirmative express consent requirements for the transfer of data. I think in HIPAA world, people are relatively used to the idea that public health data is going to flow on the basis of it being required by law or authorized with the under well-established approaches. But if you're looking to take advantage of all of these novel data sources, basically, unless a very robust consent is obtained in the first instance, where a public health use is disclosed at the time that the user engages to get that service, you're going to have to go back And if at scale and in bulk, you want to get access to this data, you're looking at forcing the provider to go back and reobtain consent for the public health use. So there's really the prospect of increased friction. It's interesting data, but unless there's a clear strategy going in from at the inception for where there may be a public health use and it's articulated, it may be impossible without beyond the operational capacity of the novel health data collector. Finally, and actually as a third point, I would say that on the consumer side, there's a rising expectation of a sense of rights and control over personal data, and this is carrying over into Washington State's legislation for health data and every form of commercial privacy legislation, which is much more robust disclosures, much more discrete requirements of explaining what's going to be done with the data, more requirements to minimize what's collected in the first place and how long it's kept, and then also rights of deletion and rights of revocation. So despite the potential interest of the data, we in the U.S. we're trending towards leaving HIPAA to the side, which is good from a public health perspective, but we're certainly trending for any other data source to a much more, I'll call it citizen/consumer rights-oriented framework, and which is different than in Europe, where in nationalized health systems, it's been easier to invoke principles of solidarity and to essentially to use without additional consent health data for public health purposes. And the UK NHS was actually doing active consultations with patients about what they were comfortable with for public health use. And it's kind of difficult to imagine a similar process, at least in the regulatory sphere as we have it today in the US. So I guess as a concluding thought, I would say that the public health needs to really be conscious, to the extent that the desire is to harvest all of these potential novel data sources. There really has to be some thought process around communicating what public health wants and why it's beneficial to the user. It's no longer going to be, at least to the extent that you want access to this novel data, it's not going to be a passive process as it has been historically, where data is simply reported as required or as authorized. And so really there needs to be a more considered communication strategy for reaping the benefits of this data. So thank you.
Okay. Do we need anything else here? We're all set. Okay. So next we have Julia Adler-Millstein, who is a professor of medicine and director of the Center for Clinical Informatics and Improvement Research at the University of California in San Francisco. And she's going to talk about how health information exchanges can support public health information sharing needs.
Wonderful. Well, thank you so much for inviting me. Can you hear me and see my slides?
Yes, it's all great.
Okay, perfect. Let me know if we run into any issues. I'm just going to stay off video just to play it safe in terms of Zoom, but I am here and thrilled to be here. Great. So yeah, I thought I would start by just broadly framing, health information exchange, which, I think at its core concept is the notion that as patients move across care delivery settings, their health information gets fragmented and, can exist in primary care with a specialist or a pharmacy or a hospital. And so how do we basically create a national health information infrastructure that allows data to move as patients move across care delivery settings? And under the 2009 HITECH Act, as we were creating incentives for hospitals and ambulatory providers to adopt electronic health records, it was very much envisioned that the ability to exchange information would be part and parcel of that. I would say by and large, while we did get a large increase in adoption of electronic health records, getting that seamless exchange of health information was not so easy, and has sort of continued to be a challenge in terms of just getting information to flow even between electronic health records, let alone between electronic health records and the much broader set of systems that we want to have connected. So indeed, as HITECH was being developed as a set of regulations, it was recognized that just EHR to EHR interoperability was not going to be enough to really transform the healthcare system through health information technology, and that there is a much broader set of organizations that are really key to connect into that information infrastructure. I'd say first and foremost, among those in that sort of broader tier were public health organizations, and recognizing that there were a set of reporting requirements already for example, reportable labs, syndromic conditions. And so given that those requirements were there, folding them into the meaningful use requirements such that, to get credit for having, a certified electronic health record, needed to be able to show that it could do some of the reporting that was required under public health statutes. But the reality is that, a lot of the way that happened was point to point, right? Like a given health system or a given practice would try to figure out, well, how do I electronically connect to my local public health department? And so there was a lot of basically point-to-point exchanges that were set up that we knew was sort of not a really optimal infrastructure. And so the vision was, well, can we instead create entities that sort of sit in the middle so that a hospital, for example, could connect to one health information exchange and have that information then go to all the other places that may be needed for all these different use cases. And similarly for a public health department, right? Could they connect to this health information exchange entity and get all of the relevant reportable information rather than having to set up these point-by-point connections? So again, in concept, a much easier framework to think about, right? Make one connection, have the data flow to many different types of stakeholders. But what this relies upon is that centralized entity, that centralized health information exchange entity that is the sort of air traffic controller for information. And the reality is that, we haven't really set up a set of these organizations across the country that ensures that they serve that function in every possible geography. Instead, it's been a much more, I would say, bottom-up, haphazard approach to, communities, some of which have established these centralized entities. At last estimate, maybe about 120 of them spread across the country, some very small, some large, some overlapping with each other. And then obviously other approaches to achieve health information exchange, some of which are more proprietary, which we also call enterprise health information exchange. And we've also seen the electronic health record vendors get into this game and start to be that centralized entity that connects up, again, different electronic health records and other information systems, which is helpful in some ways, but also been hard because oftentimes they draw boundaries around, just the entities using their electronic health record product. So again, it's been really like a patchwork of what sits in the middle, which has, I think, impeded getting to this vision of just making one connection and getting the information to flow through that sort of centralized hub. We don't have time today to talk about sort of, where this is headed, but the trusted exchange framework and common agreement, which is just being rolled out now, really is, I think, for the first time trying to solve some of this and create really a national network of networks infrastructure. So we'll see if that, helps make progress in terms of getting from that spaghetti picture to something that's at least a little bit more organized, where there's a set of hubs. You can just connect to one hub and then those hubs talk to each other. So I think we're working towards, unfortunately, from the bottom up, a more seamless national infrastructure for all the different ways that information needs to move across organizational boundaries. So if we sort of shift gears from this national picture and think about specifically like how are these HIE entities potentially helpful in the context of pandemic response, I think there's some of the obvious use cases like electronic lab reporting, electronic case reporting, and syndromic surveillance data. But coming out of this past pandemic, I think there were some additional use cases that really came to light. For example, tracking and disseminating real-time hospital volumes and resource utilization. Often this is called sort of situational awareness data. Again, serving as that single unified source of lab testing data for the particular, pandemic relevant lab tests, assuming that we have them, so that it's really easy to get a sense of sort of where things are in a particular state or even, more microgeography. And then being able to, analyze test volume and results by geography to look at, disparities and obviously, different patterns of diagnosis and fatalities. Enhanced contact tracing. A lot of these health information exchanges have a robust set of information about the people, who's ever in their master patient index, oftentimes more information than the public health authority may have. So they can be useful in sort of supplementing information to make contact tracing more robust. And again, in terms of this general theme of being able to connect broader data to the relevant public health data, for example, capturing relevant comorbidities, right? So a lot of these health information exchanges really understand the broader health context for individuals and can connect that to the public health data to be able to communicate, again, if we're seeing emergent patterns of comorbidities along with, that focal condition. So again, a broad range of potential HIE use cases. And I think as the pandemic has unfolded, different health information exchanges have sort of pursued developing capabilities to support, different types of public health specific use cases. So to further this, sort of experimentation and learning of the ways that existing health information exchange infrastructure could be used to advance pandemic responsiveness, the Office of the National Coordinator for Health IT within the Department of Health and Human Services launched this program called the STAR HIE program, strengthening the technical advancement and readiness of public health via health information exchange. And there were actually different components to this program. Some focused just on immunization reporting data, but the first STAR program was really about helping community HIEs respond to COVID-19 by partnering with their local public health agencies and to build innovative HIE services that benefited those public health agencies. And so 5 health information exchanges, and these were community HIEs specifically, were selected and awarded funding to try to, again, build out their capabilities and do it, while learning from each other, and to try to distill some of those lessons for the broader set of health information exchanges across the nation. And so my team at UCSF was awarded the sort of evaluation component. And so we got a chance to sort of look under the hood and really understand what each of these efforts did and focused on. So in the interest of time, I probably can't go through like the full set of evaluation results. I am happy to share them offline, but I'll just note sort of briefly, what the focus was. I'd say 3 of the 5 really focused on some combination of electronic lab reporting and electronic case reporting, and tried to enrich electronic lab and electronic case reporting data by adding the broader set of information that the HIE had available, whether that was race and ethnicity data or comorbidity data or data from settings that are often underrepresented. So for example, GHIN focused on connecting to correctional facilities and rural hospitals. So sort of they each had their own flavor, but at the end of the day, it was really about getting a broader set of data to public health authorities from hospitals and practices. Again, these are just sort of briefly what each of them did. And then 2 of the 5 focused instead of on sort of core public health. Did you lose me? I'm still on the phone because I was worried this was going to happen. So I'm just going to keep talking and then hopefully the slides will come back in a minute. Can you still hear me?
Yes, we can hear you.
Okay. Perfect. Sorry, the Zoom has just been very finicky. So two of the 5 awardees focus on situational awareness data. So basically trying to get hospitals to be able to share like bed capacity, PPE capacity, et cetera. So that was really the focus there of 2 of and unfortunately, one of them realized that wasn't going to be feasible, and that basically the data, where data was kept for situational awareness and the standards, et cetera, were just too immature. And so this was the Arizona HIE. So they actually just have totally shifted gears under the program and are focusing now on building. Yep.
Okay, so your slides are back up, but it's on the title slide.
The title slide. Yep. I'm going to get caught up in a minute. I can see it's just taking my computer a minute. So I'm just,
okay.
I don't want to get us behind. I'm just going to keep going, but I will get my slides caught up in a moment.
Okay. You have about 5 minutes left.
Perfect. Okay. Now, are you able to see are you off the title slide?
Yeah, we're on brief overview.
Yeah, perfect. Okay, great. Let's just hope that this will stick with me. So anyway, so I was saying that Arizona was the one who had to really shift gears and shifted away from doing situational awareness because they felt like it just, frankly, again, the data was just too unstandardized, and it was just hospitals weren't kind of willing to do the work during the pandemic to be able to share that data, to now focusing on developing their master person index to help support a set of public health use cases, including enhanced electronic case reporting. So we've looked at sort of evaluating each of these 5 and their efforts from both a quantitative and qualitative perspective. So I just want to sort of quickly spin through the data because I think it's pretty clear that, both in terms of onboarding new participants to public health reporting and expanding the data feeds that then allow them to do enriched electronic lab reporting and electronic case reporting, like those were all quite successful under the program. And then several of them also built COVID registries and were able to put all their COVID data into a registry that then they could report out to public health or public health could work with. And then there's also been a focus on data completeness. And in the interim result, we were able to see large increases in data completeness from Kanza, and several of the others, I think, have been very successful in doing that as well. And we will hopefully be getting that data soon to show sort of exactly what the levels of increased data completeness have been. So anyway, these just kind of spin through and just show you that increase in terms of participation. Again, each one took sort of had a slightly different emphasis. So this HIO focused on getting post-acute care settings connected to be able to report to public health and had a lot of success there. Here, it was really an ambulatory practice focus. This is a different HIO that worked with particular EHR vendors to get them to basically better connect to the HIE to do electronic lab reporting. Again, a lot of focus on different data feeds that could be sent, parsed and then sent on with the relevant data to public health entities. And again, I thought what was cool is that you could actually see the electronic lab reporting volume track with caseloads as they went up and down during the pandemic. So a way of sort of being confident that, that these HIEs were capturing the picture out there in the communities. Okay, so anyway, and this is, as I said, just the race and ethnicity data completeness that the HIO was able to take. We're able to take COVID test results that had about a 92% of race and ethnicity completion, basically up to 100%. So again, just quantifying that value add for HIEs. Okay, so just again, we did a qualitative piece too, where we interviewed lots of different stakeholders that were involved in different parts of this. And again, I think what we heard was that these were largely successful, that HIEs did play a really important role in leveraging their more complete set of data to bolster electronic lab reporting and electronic case reporting. And again, that was really perceived by the public health stakeholders as well as the HIEs as a clear value add. It also just really strengthened the relationship between these HIE entities and public health, and has really led to this positive effect of okay, what can we work on next? That really was helpful for COVID. What can we keep partnering on? And so really just that sort of impetus to force these two entities to work together under the pandemic, I think will really pay dividends in the long run. And public health entities said, oh, like now we get why HIEs can be valuable to us. It's like they didn't really believe it until they had seen it under this program. There were some limitations, of course. You know, I think lack of funding and turnover and, you know, just all the things that we know happened during the pandemic we did here kind of limited the ability to make as much progress as everyone had hoped. A lot of why this was successful was really work behind the scenes, in particular working with electronic health record vendors to say, like, how do we do this connection for all Athena practices? So you didn't have to go practice by practice to get things connected up, and could really just work with the vendor and then roll out that solution to a large group of practices at once. So the HIEs were really helpful in particular at doing that sort of technical behind the scenes work, so that practices and rural hospitals and correctional facilities like didn't have to do it on their own. Again, the technical work of connecting up their system to the public health system. I'm just going to skip through this because I think this is less critical. The situational awareness data, I'd say, you know, did really have more major unanticipated challenges. Again, just even how do you measure PPE volume and how do you measure staffing and bed availability? We don't even have good sort of standards around how to represent these concepts. So then to do the data reporting, you know, is very difficult because we don't even really know what, you know, how to measure things. So like a bed is not just available or not available, it can be in like transitional states of availability. So there was just, I think, a lot of challenges there, and something where future work could really help is getting those situational reporting standards to be more mature, so that HIEs can be more helpful there. And in general, there was a lot of hope to use like novel technical approaches here that just didn't really pan out because, you know, fire standards and, you know, they're just not mature enough yet for a lot of these HIE use cases, or the EHRs didn't have them implemented yet. There was also just the sense about like trying a new technology during the pandemic is like not the right time to try something. So it may be that it's really in this post-pandemic period where we're going to see more advances in the novel technical approaches to public health data sharing. Okay, so this is my last slide. I hope, you know, that kind of some of these early lessons from the STAR HIE program will be more broadly useful for the nation to see that HIEs do play a really important role in particular sort of the technical work and creating a more comprehensive set of data for public health. And, you know, where there are challenges, I think, you know, we can work on them, like, you know, information and reporting methods that are not standardized, particularly for new situational awareness data. And just how do we overcome the inertia, particularly during a pandemic where there's, you know, personnel turnover, technology challenges, and concerns about like knowing whether the data is really valid and representing a current state. So, you know, these 5 entities were lucky because they got federal money to sort of push that HIE public health partnership. So I think a broader challenge is sort of how do we get the rest of the country to have that nudge and to work more closely between HIEs where they exist and their public health partners. So that's it. Apologies for the small technical glitch, and look forward to the rest of the discussion.
Thanks so much, Julia. That was great. So next we have Cason Schmit, who is an assistant professor and director of the program in health law and policy at Texas A&M. I met him many years ago when he was at the public health law program at the CDC. And he is going to be talking about opportunities and challenges for AI-enhanced public health surveillance.
Thank you so much, Sharona. It's a pleasure to be here and an honor to be among these panelists here. I'm going to keep my video off because my Zoom has been a little unstable lately, so we'll see how it goes. I'd like to begin my talk, as I begin all my talks, with a eulogy. Charles mentioned this earlier, so I'm not going to spend too much time here, but I think there's a tendency to become enamored with the shiny new thing that comes along. And with regard to Google flu trends, it was incredibly buzzy, and it worked very, very well until it didn't. When it was predicting things that, you know, with far greater severity than actually ended up occurring. And I don't want to rehash why it failed exactly, because I don't have time. But a lot of the same reasons why it did fail are reasons why we need to be careful when implementing the shiny new thing of AI in the future. And one of the big questions I do think we need to ask ourselves as we embark in an age of AI-assisted public health is what can be improved with the new tool? What can be improved with the new technology? As with Google flu trends and the CDC data, it was trying to improve something that was already pretty good. And our public health surveillance system, it's not without its faults, but it's pretty good and it's pretty robust. There are many different systems that make up public health surveillance, and each of them does its purpose pretty well. And AI applied to any of these systems is going to need to somehow fix those deficiencies or do better in a way that doesn't introduce new risks or new harms by virtue of a new technology. Now, it's going to be impossible for me in 15 minutes to cover all of these different surveillance systems because they each have different infrastructures and different legal frameworks. And as a result, the opportunities and challenges posed by AI will vary for each system. So in the nature of just to be brief here, I'm going to focus today on syndromic surveillance for a few reasons that I'll get to later. But for those of you who are not familiar, syndromic surveillance really came into focus after the 9/11 terrorist attacks, particularly the anthrax ones. And it was funded and implemented broadly as a tool for early detection of outbreaks and epidemics. It hasn't really been used for that purpose. Instead, it's been used quite effectively to assess healthcare needs after major disasters such as hurricanes, to characterize the overdoses such as opioids and other drug-related overdoses, to monitor early signs of outbreaks, particularly after large gatherings, concerts, conventions, where there might be compromised sanitation, and also to respond to foodborne outbreaks and inform product recalls. Now, syndromic surveillance is at its core an important tool for situational awareness, and it comes with a very important and significant trade-off. Syndromic surveillance is fast. It is very fast, near real-time data, but this comes at a cost of quality. It's messy data. It's data that its quality is sacrificed to get it to where it needs to be quickly. And to give you an example, oftentimes many syndromic surveillance data come from emergency departments. These are subsets of electronic health record that are automatically sent to a health authority or at the health authority's locker in the National Syndromic Surveillance Program. This is pre-diagnostic data, so this isn't confirmed cases as we might get in case reporting. These are what essentially is happening is the epidemiologists have these validated definitions that they use to classify different EHR fields into syndromes of concern. And they're drawing largely upon fields like chief complaint, which often is free text, and diagnosis codes. Now, why are we focusing on syndromic surveillance for AI? Well, one reason is I just got done writing a 100-pages report to the Council of State and Territorial Epidemiologists. And if I'm going to write 100 pages, I'm going to talk about it. So other probably more significant reasons and appropriate reasons for this talk is that the infrastructure for syndromic surveillance in the United States is quite robust, and I think it's favorable to an AI implementation. All syndromic surveillance, nearly every single public health authority that does syndromic surveillance sends all of their data to the National Syndromic Surveillance Program housed at CDC. So all syndromic surveillance data, the raw data, is in the same place. And we're talking about a lot of data. 7 million messages per day are sent to the National Syndromic Surveillance Program. We're talking about fast data. Updates to the National Syndromic Surveillance Program occur within 24 hours of patient visits. So this is near real-time data. And the coverage is very, very good, with nearly 73% of the country's emergency departments contributing. And we're not just talking about emergency department data. We're talking about a huge variety of different data sources, including urgent care centers, Veterans Affairs systems data, federal hospitals, laboratory data, pharmacy data, environmental and weather data. So just a tremendous variety of data that's all sitting in the same place. And this takes us to one of our first opportunities for AI and syndromic surveillance, and that's the availability of rich data for machine learning, particularly when we look at care data from emergency departments or urgent care centers or hospitals in combination with laboratory data and pharmacy data as well. So that's not to say that all the data is there right now. It's not. But the infrastructure is quite favorable to, and the opportunity is quite good for it to be there in the future. Now, syndromic surveillance is all about speed. It's all about detecting events as they are occurring. And so it's really important to find those critical signals within this messy, noisy data that's coming in. And one of the epidemiologists that I interviewed as part of my work with the CSTE had an interesting quote related to this. It says, I've struggled with some syndromic surveillance uses, trying to track down a single Ebola case, spending months working on an Ebola case definition from syndromic data, which isn't the right way to go. He says, if you end up finding a case of Ebola when we're looking for it in your syndromic system and you haven't heard about it yet, you're already screwed. You missed the boat. It's critical to be able to spot these types of conditions with the utmost speed. And having automated processes or artificial intelligence assisted detection could potentially provide a lot of benefit here. And along similar lines with what that epidemiologist was talking about, it says that there's an incredible opportunity in using AI to help define and refine the definitions for these syndromes. Essentially using the AI to make sense of all of the messy data, right? This is something I heard time and time again from the epidemiologists I talked to during this work with CSTE. They want some help. They need some help in really nailing down these definitions. And a big part of the problem is much of the critical information is in these free text fields. This is a great opportunity for AI assisted natural language processing opportunities to be able to parse those fields, pick out the important elements and disregard those things that are not. And another challenge with syndromic surveillance data is the huge variation in documentation norms. Data are entered differently in electronic health record systems, regionally, by facility, by the type of electronic health record system that is being used. And AI could be a huge assistance in helping to parse through those differences and pull meaning wherever it lies within the record. Now, both an opportunity and a challenge is federalism. This is the structure in which and the relationships between the federal, state, and local governments. And as many of you know, public health system in this country is largely decentralized. And that has consequences. And one of them during the pandemic and actually more broadly is that federal access to state and local syndromic surveillance data is severely limited. So what you're looking here on this slide is a map of all of the HHS regions in the country. The federal employees within the National Syndromic Surveillance Program do not have access to the syndromic data that they have, the state and local syndromic data below these HHS regions. And that makes it incredibly difficult to identify emerging patterns and anomalies in all of these data that are coming in when you're at such a high level. Notably, too, there was quite a bit of straining of the trust and relationships between these partners as a result of the lack of access, at least in the initial days of the pandemic. But federalism was also an opportunity. Federated learning is unrelated to federalism, but federated learning is a process in AI where AI models can be trained on different data sources that reside in different places without having somebody access all of those data separately. And this might, in the context of syndromic surveillance, this might mean that an AI-assisted syndromic surveillance tool could be developed that learns from all the jurisdictional data that's kept in separate lockers without the states first giving the federal government access to those data first. And so this might be an opportunity to deal with some of the federalism challenges that exist. Challenge for AI and syndromic surveillance. Got to start with privacy. Now, while syndromic surveillance data, there are attempts to de-identify it, these data are highly sensitive, and they will remain highly sensitive just by their very nature. Now, generally, there is an ethical consensus that there is an obligation on both governments and individuals to participate in public health surveillance. The key is not whether or not syndromic surveillance should be done, but it's about the question is, how do we do it? Good governance has paramount importance. Transparency and accountability are critically important. In the context of AI, transparency and accountability have a special importance. Another challenge that has been alluded to by a number of the speakers today is that sometimes there are challenges, that the default is that to not use the data for a new purpose or not to share it for a new purpose. These defaults persist, and it takes some time to get past those defaults to get to yes. And until then, these normative defaults continue to frustrate public health surveillance. I think the real question when it comes to the challenges for AI and related to privacy is what guardrails are in place to restrict those inappropriate uses? How can we keep these new AI tools focused on promoting population health and not doing something else that's inappropriate with these rich data? Trust and transparency, similar to Google flu trends, there are AI and machine learning are often black box processes. It's difficult for us to understand whether or not we are getting truly valid results from an AI enhanced system, because it's very difficult to see how the system is giving you the answers it's giving you. There's a transparency issue here, and understanding how reliable these results are, particularly over time, will be a challenge. There's also a challenge trying to figure out what biases exist within the results. The AI tools will inevitably be biased in terms of those areas that are providing the most data for training. So those areas that are experiencing hypersurveillance, there will be benefits to that in terms of the models being tailored to their specific situations, but there are also risks to that, particularly in terms of privacy. There are also benefits and risks to hyposurveillance. You might have entire communities that are overlooked, and the risks and threats facing those communities will be completely invisible in some situations. How do we deal with these problems?
Cason, we need to finish in about a minute or two, okay?
All right. Well, I'm going to go ahead and skip the legal framework because a number of us have addressed this. I will say that governing AI is a major challenge that we need to focus on. I will argue that policy innovations are needed due to the unique challenges of AI. I am partially biased because I just published on this in Science just a month or so ago, but I won't go into that. I think that the real question is that we need to ensure that AI is ameliorating and not exacerbating inequities. I think there's a real question about public health capacity. Public health workforce is already at capacity. Who will act on the new AI generated insights? And what's the point of AI enhanced surveillance without capacity for public health action? I would argue that if AI leads to discoveries of new public health threats, then those discoveries will empower communities to request and receive additional assistance. So I think there's a value to AI and assisted surveillance, even if there is no capacity to act on those new threats. AI is going to have profound implications of public health. I think it's a tool for public health practice. I think AI is also a structural determinant of health. And I think we need to think in public health long and hard about how we mitigate the harms from AI, how do we enable the benefits of AI, and how do we avoid existential catastrophe as what is being sensationalized. That's my last slide. One thing I will mention before I give up control here is we are hiring a postdoc on legal issues with data privacy. I'm going to drop some details in the chat. Thank you so much.
Thank you, Cason. That was great. Our fourth and final speaker is Tara Ramanathan Holiday. She is an attorney, and she is the Data Governance and Policy Branch Chief at the Center for Disease Control and Prevention. Her topic is public health data policy across the ecosystem, risks and opportunities.
Hi, can you all hear me?
Yes.
Great. Good afternoon. I just received a note on my phone saying that we are also having remote desktop issues today. So I'm going to maybe go off camera and keep my phone handy in case the same thing happens to me that happened to Julia. But it's so nice to talk to you all today. Hopefully you can see my slide deck as well, but I'm just delighted to be here for a couple of reasons. The first is I've worked with Schmit and Cason over the years, and it's a real honor to be here presenting to this workshop today. And the other is I'm actually now leading this kind of unprecedented new thing at CDC, and it's a branch devoted almost entirely to modernizing data policy. So I'm just really excited to share what's going on and delighted for the opportunity. So starting off, I am supposed to provide a disclaimer. Let's see if I can get that up. There it is. Just essentially, these comments are my own, not CDC's position or policy. So keep that in mind. So data at CDC, I kind of wanted to give like a snapshot of what's going on. We heard a lot about sort of how data is collected in different places from the prior speakers. I think about the national health system from Chuck in the UK, and how sort of public health data comes inherently because they collect data on individuals already. And we've heard about, of course, all of the varied US public health data sources from Julia and Cason. At CDC, you probably know, but data comes from all 50 states and over 3,000 local jurisdictions. Here, I'm actually hearing a little bit of, I'm gonna stop my video, hopefully that'll help. Okay, so it comes from everywhere, and actually directly from communities when it comes time to certain environmental types of surveillance. It comes in all kinds of formats, different kinds of timeframes, different resources attached to them. And during emergencies, data sources really can expand and flex to kind of include new facilities, types of data, and so on, everything that we've seen, different types of populations. And so, you know, sort of out of COVID-19 and in 2020, out of that really came some pretty foundational new things. One of them being CDC's data modernization initiative. It's the first time really federal funds have been put towards modernizing public health data. And this is, you know, just straight off the website. It's a multi-year, multi-billion-dollar just sort of effort here to make data move across the public health data ecosystem. It defined what it was. It was put towards infrastructure and health IT, public health infrastructure and connections to IT, and started to identify lots of gaps and inefficiencies. So I'm not going to belabor this, but what I found really interesting, you know, before I took on my current role, is that on the Data Modernization Initiative website, one of the main things that it talks about right here in the front is policy and standards. And this is one of the first times I've seen at CDC where some big, you know, big dollar, but also big staff, big resource activity is contemplating how it is going to approach not only modernizing the public health activity, but modernizing the public policy activity and public health policy activity that has to support it. I was really excited by that. I got to take part in that, developing that a little bit. I was at the Office of Appropriations at CDC for a little bit. But here, out of that, kind of came a new office devoted to really this long-term activity of not just modernizing, but then continuing to innovate upon that initial sort of public health data modernization. So this is the Office of Public Health Data Surveillance and Technology. I'm still trying to figure out how to say that acronym. Some people say OFITS. I'm saying DST for now, but I am now kind of have one foot in this as well. I'm on detail to this office to set up essentially a branch devoted to data policy within a unit devoted to standards and data policy. So exciting times at CDC for this. I think it's also pretty interesting. So the goal of this data strategy, it's to operationalize how we do this, at least over the next couple of years. There are 4 real big goals. None of them are going to seem particularly crazy to folks who work in this space, but we need to strengthen the core of public health data. We need to accelerate access to analytic and automated solutions that support public health investigations, advance health equity, and share insights with the public. And of course, we need to improve open and interoperable public health data, both at CDC and of course in the public health ecosystem overall. And so obviously, you know, from this sort of data strategy, I have to kind of highlight the examples of what it is designed to solve and to address. And you'll see here, this is simply illustrative, but you'll see just a very simple diagram of what we're calling generally the public health ecosystem, and some challenges that we've actually seen. About 70% of healthcare organizations are using fax to send or receive healthcare records. 80% of EPI's time is spent cleaning data because systems themselves are not very interoperable. Over 30% of COVID-19 cases are missing data on race and ethnicity early in the pandemic. Over 6 months were needed to develop and potentially rework data use agreements. We're going to come back to this. Over 12 months on to collect data on reportable conditions through national data sets or disseminate that data in useful formats. And then around 3 months between having a first reported domestic Mpox case and having CDC data access agreements with jurisdictions. Stilts here, for those who are not federal folks, it's state, tribal, local, and territorial jurisdictions or health departments. They're kind of used interchangeably, but we call those stilts, another typical acronym. So whoops, I went a little forward on that, but I wanted to kind of spend some time talking about these sort of foundational concepts. And some of them won't be particularly surprising to you, but I'll try to talk about what CDC is doing in this space to make it a little bit more useful and real. So the first is around data authority. This has been going on since the start of the pandemic. We're really thinking a little bit better about how data comes to public health. Certainly, we know, obviously, it comes from a whole variety of places, you know, everything from hospitals and labs and doctors to schools, restaurants, community locations, associations, and so on. We've talked about the variety of formats a bunch, the types of reporting mechanisms, and occasionally original sources of data. We have adverse event reporting for vaccines that comes directly from individuals sometimes. And of course, data can come to public health that needs to be cleaned and assembled and analyzed before it can actually inform us in what we need to do. And that's, you know, it's great to hear about sort of the work going on in AI and thinking a little bit better about that. Folks at CDC are doing the same. I just talked to a program, you know, speaking of data sources, that has this process for getting data. Getting data alone is its own challenge for this particular program. It has sources that range from a state registry, which is voluntary reporting to that registry from healthcare. It relies on hospital discharge data, Medicaid claims, emergency department data, vital records, and clinical data. And it takes just an enormous amount of time, if you can imagine, to link those data sets and figure out how to get them to health departments. I believe the health departments have to sign all of these MOUs and different agreements, and then CDC has to then work with the health departments to figure out how to bring that data together according to the terms of those MOUs, and then link that data to existing federal data. So in real life, this is it's a huge undertaking. And this is just for one program at CDC. You know, we rely at CDC very much on cooperation with jurisdictions. So these jurisdictional public health authorities. So really these stilts are collecting data under their own authorities. And then it requires a lot of goodwill from those partners and kind of receiving the data and helping to share it with CDC. So we're thinking about data authority and how to modernize that, because standardizing how data are reported would allow better data for all of our partners, as well as obviously for CDC, and less burden on the providers to report it. It also would ensure that data would be shared securely across public health, which a lot of attention is spent sort of case by case at this time. It is not centralized in any way, and that's kind of going to be a theme you'll see. So I'm going to move on to another topic here, which is interoperability. Now, this includes a lot. CDC is doing a ton of stuff in this area, HL7 fire activities, something called North Star architecture, which is shared cloud infrastructure and potentially services for our still partners. And of course, TEFCA. For those who are, you know, new-ish to TEFCA and have just heard about it today, I think it's really, honestly, one of the initiatives that's further along. It's a collaboration with, as Julia said, with the Office of the National Coordinator, ONC. And so I'll kind of start here. You know, we plan to participate, CDC plans to participate in TEFCA, like many public health agencies. And we're developing things like demonstration projects and governance and linkages to support the work. But there are significant issues that remain, and I kind of highlighted two right here. The first is, you know, really understanding our authority to receive data and the authority to then keep the data. I'm using lay terms on purpose here, so stop me if I need to clarify, but there's no real explicit legislative authority at this time for CDC to receive identifiable data, but there's also no prohibition. So at this time, we kind of receive relevant information within the context of the Public Health Service Act. We do have authority for certain data collections, which, you know, can potentially raise questions about how implicit and explicit authority work together and what happens to non-enumerated data collections, for example. We have obviously Privacy Act requirements that protect against disclosures of PII. We have Paperwork Reduction Act requirements that restrict data collections that are burdensome outside of typical government business. We have certain kinds of elements under data collection, so the right to possess data that have to go through our Office of Management and Budget and Executive Branch for review. And then, of course, we have sort of what happens if there's a mistake, case report sent to CDC by mistake and so on. We have to delete some of that personal information. We have to make sure we comply again with Privacy Act. We have a whole, system of records process for that. And then finally, the second piece here is really the legal authority to send data without creating. Wait, what did I just talk about? I just talked about the collection of data. I'm sorry, the top one here, the disclosure. So the authority to send data without creating a problem with HIPAA, a breach, anything like that. So we have to receive permission from OMB, again, to receive data, but also we usually put DUAs or data use agreements in place where healthcare has to, sign on to, for example, in this case, a qualified health information network to participate in TEFCA, and then that allows them to send certain data to CDC. You could do it that way. There's a bunch of other options, of course. And then, of course, if a public health agency actually gives permission to send CDC data and CDC gets the permission to receive that data, what happens with intermediaries and how we work with intermediaries as throughout public health, and which authority needs to give permission in order for that intermediary to then share data. So all of that to say, this is a busy area. And then the third sort of area of work is really operationalizing a whole bunch of federal laws, statutes, regs, policies, executive orders. You'll see here, there's a federal data strategy. I mean, I think the number of people involved in this is significant, and figuring out how to move it forward into an area of an era of cloud-based work, and certainly, with a view for sort of an open data, public data process in mind. I think it's a real undertaking. So I'm not going to belabor this. I realize we just have a little bit left. I want to kind of give you guys a snapshot of what we're doing right now. So back in November, CDC's advisory committee, the director, has a data and surveillance work group. It's not very often that this is stood up, but it was during COVID-19. And they voted and kind of came up with 3 recommendations. They did a lot of sort of background research. They had findings, and they found really 3 things. The first is that public health infrastructure, including data systems, were out of date and not aligned to healthcare information technology, of no surprise. They also found partners who report data have really differing standards or requirements around that data across different jurisdictions. They have different costs and technological barriers, really problems with interoperability. And then finally, there are many inconsistencies in how we approach legal agreements that lead to significant variation in how data is reported, when it's required, when it's needed, how the data is used, and then how it supports national and local situational awareness. So kind of coming back to what today's purpose is, this is all kind of showing us that the CDC's data policy is not quite response ready. So there are 3 recommendations here that this report came up with. The first is to define minimal data, what's necessary for core public health data sources, which I'll mention in a minute. The second is to establish public health data systems, standards, and certification, which I'm not going to go into today, but happy to answer questions about it. And then to establish data use agreements and frameworks to actually make all of this run. So one of the first things that we're actually working on under this public health data strategy is to work under these core data sources, trying to figure out, this is how the ACD report defined core data at CDC. You'll see these all have different pathways to, for the data to actually get to CDC, let alone a health department. There are different requirements, different state law requirements, local law requirements around these data. And certainly not only the level of data is kind of different across these, but there has to be some type of minimal data necessary. So base standards where public health just simply needs certain things from each of these sources in order to share and exchange data effectively. So that's something we're trying to develop. I'm not
Tara,
going to
we have maybe 1 minute left.
Yep, got it. Thanks. The second one is really about the system standards and certification. I'm not going to talk about that, but this is a collaboration with the Office of the National Coordinator of Health Information Technology. And the last one, which I did want to kind of take a second about, is about data use agreements. And this is, we've spent a lot of time because you have to define essentially what is use, what is sharing, and define our expectations around those. But we're trying to communicate sort of foundational legal responsibilities for public health. Our authorities, the other side, so the jurisdiction that we're working with, their authorities, certain prohibitions, certain data collection requirements, how we transfer data, how we dispose of data. This is obviously not exhaustive, but this is where we spend a lot of time, and I'd love to kind of answer questions about this. But throughout this time, we've kind of realized we have to include data policy modernization when we think about modernizing CDC's data, and certainly that all leads us to better preparedness. This is that same model I showed you at the beginning and sort of where we want to go, and you'll see everything is about increased stability, better speed, again, speed here, and real like public awareness. I think that's where we're trying to go. And really we're trying to plan around data policy as an enterprise-wide institutional activity with sort of forward-looking agreements, strategic standards, and operational governance. So I'll stop, but I'm happy to answer questions, and thanks so much.
Thank you. So, yeah. So we'll take questions from the audience. Do they have to come up here to the microphone, or?
Let's do it fine.
Okay. Who wants to ask a question and see how sensitive this microphone is? Go ahead.
Chuck, you mentioned about use of data collected for other purposes, especially commercial kind of data, and then repurposed for, let's say, modeling a disease or something like that. So my question then is, we do that all the time, right? We pull down Johns Hopkins data, for cases and deaths. We don't ask permission, we just pull it down, and then we calibrate our models using that. And we also bring in movement data from third-party suppliers, with all de-identified. So my question then for the legal people is, public health by definition, is that a public goods kind of thing? And so how does that impact, data provision and usage?
Did the panelists hear that other than Chuck? Did the remote people hear that? No. Okay. So it's okay. You asked it to Chuck. You asked it to Chuck.
Well,
So
the question was essentially de-identification that's that then relied upon by researchers, and how do we assure that? I covered novel use cases, but all of the other panelists, Cason and covered the governmental. I think it's incumbent, whether it's a novel data source or whether it's traditional data emanating at a core level from clinical or through a traditional reporting channel. Each silo is responsible for meeting the de-identification standard for its silo before it's published on the web, which is a higher standard of proof or de-identification than it is merely for internal use. Or so by the time you see it, it's had to meet the highest possible threshold of de-identification for that particular silo. So I think that's I guess the challenges arise when you mix data across different silos with potentially slightly different de-identification requirements. Where you've combining something that came out of where you've tried to use some sort of record linkage to harmonize these data sets and then try to publish it. So, but I'll let the true experts from the CDC and speak to that in terms of how do you deal with publication given the public's insatiable appetite for data sets. How does that factor into data policy?
I think that was to me, is that right?
Yes.
Okay. I think I hate to say it this way, but it sort of depends on the type of data you're talking about. There are so many different ways, as I've mentioned, that data comes in. Some of it is super non-controversial, covered by assurances or certificates of confidentiality, things that are already set up for researchers to come in and use. There are types of data that we get that honestly CDC is trying to figure out how to use, and we have a new Center for Forecasting and Analytics that is trying to come up with how we do that. There are plans for how to publish and make analytics available and how to kind of work on big new sources of data and make them meaningful. How much of all of that has identifiable information is, again, sort of for different programs, it will differ and depends on the silos under which data comes in under all those different authorities. So it's hard to say across the board in a meaningful and useful and operational way. Certain programs, obviously, can think of, communicable disease surveillance requires a lot more. And so it does, every person that works on those data, we work on NDAs for folks who have different types of permissions. And then by the time we kind of clean it and make it available to the public, we not only need to be cognizant of sort of how individuals are protected and, we can't reverse identify people, but also we need to make sure that we're not trying to, provide information that a jurisdiction views differently, because they do their own analytics sometimes, and they also kind of have a different sometimes idea or scope around how a disease is moving and transmitting and so on. And so we typically work with them. So there is a bunch of stuff that happens before it becomes publicly available. And depending on the source and depending on the purpose and the use, we're trying to make it faster for certain things.
Other questions from anyone? And I think you need to come to the microphone.
So I had a question for the first two speakers about HIEs. I'm just wondering to what extent a individual health system has control over their data used for public health purposes once it goes into the HIE. Can a single health system put the brakes, potentially on sharing of data for public health purposes in that sense?
Great question. We have been hearing a lot about this as we're doing our sort of summative round of evaluation activities within the STAR HIE program, because during the pandemic, there was sort of a pause on some of the requirements around purposes of use of data for public health reporting, and those, I believe, on May 11th will kick back in. And so a lot of health systems, I think, are both health systems and HIEs are sort of worried about what things will look like as we go back to sort of the prior regulatory framework. I mean, I think the short answer is yes. I mean, health systems voluntarily are participating in HIEs and do get to influence what the policy is around what their data can be used for, and I don't think they can be forced or compelled to use it by the HIE, but obviously the value of the data for public health is in that broader use. And so it's really this tension, I think, between health systems wanting the protections and some, I'd say, concern about the breadth of uses that they may or may not feel comfortable with. And so I think that's really an active space of negotiation between the participants and the HIE itself to figure out what the bounds will be as we come out of the sort of pause of some of the regulations during the pandemic.
The only thing I'd add to that is that depending on state law and whether the HIE is chartered by the state, there may be opt-out or even opt-in requirements applicable to whether data is upstreamed in the first place from the individual hospital into the HIE system. And I think most states are opt-out, but that would imply not just the primary opt-out for sharing with other health systems, but also the secondary use for public health. So opt-out mechanisms, which are, I think I heard somebody from Pennsylvania's HIE say that they'd had 300 opt-outs across N million users. So they're infrequently used mechanisms, but they are in effect, individual patient controls for health delivery and for secondarily for public health. So those mechanisms exist at law, but are infrequently used.
Jing.
Rona, there's a question on the Zoom too.
Okay,
Oh,
well,
okay.
we'll let Jing go and then we'll get that.
Yeah, my question is regarding the National Syndrome Surveillance Database. And it seems indeed a very good resource for AI model to build AI models. But how about is it available to researchers in the university? How can get access to that database?
So I think that's a question that the National Syndromic Surveillance Program is working on. I do know that they do have partnerships with some universities to do answer some research questions. It's not data that they make publicly available as sort of a default because of how sensitive it is. And because it's so messy, it's really, really difficult to ensure that it's adequately de-identified before releasing it. So for example, you might have a name in the chief complaint field, which is a free text field, which is very difficult to scrub before it's being released. So that's something that, you know, if you've got questions that data set could be answered, reaching out to the people within that program is a way to go.
Yes.
Good question.
That was not actually a question. I think that was the advertisement. Cason, you're the one that had the job, right? So that was in the chat. Oh, Brian, you have your hand up?
If there's time.
Yeah, go ahead, quick.
Just curious, connecting sort of Chuck's and Tara's conversation, or excuse me, presentations. Is there any discussion at the policy level around trying to revive and make better digital contact tracing, and relevant to what one of the points Chuck raised, to try to avoid the platform power that was exercised by Google and Apple to essentially eliminate digital contact tracing and convert it to something much less useful?
To the extent that you're looking for federal policymakers to intervene, let's say that probably is not at the top of their agenda for big tech, just in terms of, you've got the social, social content moderation. They've got a whole hit list of things that they do want to hit. So unfortunately, empowering public health uses of the data from those platforms is just not likely to rise up to something that gets action from a divided Congress. And in fact, really, it's a real problem that we now have divided government at a time when so many, with all of the lessons of COVID fresh in mind, we're unable to funding wise, good things have happened, but certainly it's more difficult to get to some of the authority issues than it was in the last Congress. So in effect, your question is subsidiary to the larger question of how does the federal government make data better generally? And we are still in a federalist system where federal intervention is more sporadic than it hopefully we would want it to be.
I can kind of take a stab at your question a slightly different way. Contact tracing is typically done at the local level. And because of that, I think, trying to have enough information to be able to effectively trace and use geographic, whatever the, private entity is providing in terms of information effectively at the outset will require understanding sort of that local level sort of need and what they have in terms of how they do contact tracing right now. So I kind of agree. We don't have, as far as I know, national level plans for this because it is somewhat of a local issue, but also at the same time, and done differently in different contexts in different ways. But at the same time, we have a whole bunch of partnerships with the various organizations you just mentioned, to try to figure out if there are, easier ways to detect, water towers for Legionella outbreaks, figuring out where those are, how to, that there are environmental cues that sometimes will be more obvious with some of the tools that Google and other software companies have. So we're doing that kind of through partnership informally.
Thank you so much. I think we're going to have to end there and move to our last panel of the day, but this was a wonderful program, and thank you so much to all our speakers.